So we have with us our next speaker, Dr. Rushi Deshpande. He is the director and HOD at Jaslok Hospital, and he is mainly involved in renal transplantation, and he's a gold medalist. So you can see on the screen his introduction, and yeah, I now quickly hand over to Dr. Rushi Deshpande so that we can take this forward.
Good afternoon, everybody. First of all, a big thanks to Dr. Ashwin Upalkar for giving me this opportunity to interact with all of you. It's a pleasure and it's an honor to follow the two speakers before me. Actually, I learned a lot from their talks. So the talk given to me today is the future of CRRT. Future is like, looking into a oracle or, I don't know, glass ball to predict what's next. So can't do that, but let me try and see what I can to tell you where CRRT is headed. So this is how I've scheduled my talk. Let's introduce the CRRT, give a current status, what are the principles, modalities, might be a bit of a revision given the first two talks, integration, limitations of existing, why do we need a future, why are we not complete at the minute, and what else can we do in terms of improving our techniques and creating a better future. So we know that God-given kidneys work for 24 hours. So when I joined nephrology, one of the first things to me was a substitute for the kidney should work 24 hours. Why is it working 4 hours 3 times a week? And CRRT and peritoneal dialysis, these are the two techniques to me which mimic the natural kidney. And ideally they are the ones who should be used to replace renal function whenever we need it. So CRRT, the history over the last 40 to 50 years for people who like to know a little bit about history, suffice to say that continuous renal therapy is basically an extension of our regular dialysis, except that the techniques used has to be, whenever we use something for 24 hours, we have to be more sure about the compatibility, the risk of infections, and basically over and above, CRRT is expanding now to cover all extracorporeal therapies. So here at Reliance Hospital, we had the honor of setting up the first critical care nephrology department in our country. And we have a fellowship training program for nephrology and ICU graduates who wish to subspecialize in critical care nephrology. And CRRT is the backbone of this therapy, as you all realize. So why do we use CRRT and why not just dialyze them? Because it's a gentle, gradual removal of fluid, better tolerated by patients with lower blood pressures. Because it mimics the natural kidney function more, the tolerance is better, and so are the results. Superiority of CRRT is always something which will be debated, particularly with the newer hybrid forms of dialysis, which are like a cousin of CRRT, but they are not called CRRT, right? So the basics, this has all been gone over, so I'm going to skip a few of those slides. Basic processes. So the only thing I would like to speak here is one word. Convective clearance is for solute clearance. So whenever you are looking at middle molecular clearance, your inflammatory molecular clearance, you need convective clearance. When you are speaking dialysis, you speak small solute clearance. If you want to just correct the acidosis, hyperkalemia, uremia, diffusion is enough. When you are looking at the adjunct to sepsis treatment, when you want to remove middle molecules, you need convective clearance. And like I said, any purification of blood outside the body, that falls in the domain of critical care nephrology. So whether it is about removing the light chains in myeloma with a high cut-off dialyzer, we're using different kinds of filters in our treatment, which we'll go about, which is what the future holds for us. So these are the different modalities in practice, which we do. Even blood purification, like I said, anytime blood is out of the body and getting cleaned or treated, it is under our domain. So therapeutic plasma exchange is when we remove the plasma, the unwanted antibodies from the plasma. It's fairly non-specific because we remove the good and the bad, but it helps in certain illnesses where the bad is much more than the good in the blood. Like suppose you have a myasthenia gravis and you remove the antibody for myasthenia, the patient recovers. And we have all seen that in practice. There are some renal indications like vasculitis, Goodpasture syndrome, TMAs, thrombotic microangiopathies, where we do such treatments. Hemoperfusion. Now, hemoperfusion is seeing a newer lease of life. Hemoperfusion came from the days of chloral hydrate and barbiturate poisonings, when we used to do adsorption with charcoal. Now, there are better and better adsorptive technologies available, and these adsorptive technologies are helping us remove toxins in blood, which are they are getting more and more specific. Suppose I was to tell you something like a gram-negative sepsis, there is circulating endotoxin, and you use a filter that specifically binds only to the level endotoxin in the blood, right? Which is what our polymyxin filter tends to do, and it will only get better as the technology evolves, so that you remove the endotoxins and your patients with sepsis get better. So you don't have renal failure, but I'm starting you on CRRT with hemoperfusion. So obviously, all of these treatments are also expensive. They are not really, cheap by any stretch. But if the results are there, then obviously the costing will improve over a period of time, and patients will recover. So this is what I was talking to you about diffusion versus convection. So the small solutes are removed by diffusion, the middle by convection. The large cannot be removed by our current treatments. Different types of filters, and this is where the future has developed over the last 10 years and will evolve over the next 10, 20 years, the way I see it. Because the technology of diffusion, convection, the basic physics, that's the same, right? Diffusion, filtration, convection, adsorption, that's not going to change. What's going to change is the armamentarium that we are getting in fighting these illnesses. So the better filters, if I give you a filter with a higher flux, your ability to remove the middle molecule improves so much more, right? And if I give you a high cutoff filter, then you are actually able to remove the light chains, which you would want to do in a patient with myeloma with circulating light chains, because these light chains are precipitating in the kidney and causing renal failure. So till your medicines for myeloma take over and stop the production of those light chains, my therapy will help you by time. So this is where I can give you more and more examples. So this is bilirubin filter. So my first experience with using a bilirubin filter was, I think, 3 years back. So a patient came with, conjugated hyperbilirubinemia and was in encephalopathy, and there were no other problems in that particular patient. And we used a bilirubin filter. So there are these filters which are available, which are bilirubin specific. And you use these filters, and the bilirubin comes down by almost 80 to 90% from its high. Now imagine if a child with kernicterus, you have this luxury of treating, then you are never going to get brain damage. So the indications are only going to expand. Biocompatibility, citrate. So again, the one question comes, and I don't think it was part of today's talk, but one question comes is, how do you make sure that the blood remains thin and not clotting? And regional anticoagulation is the need of the hour, and technologies are improving in this regard, and we are going to see more and more improvements here also. The indications. So when I was a student, we used to say indications: refractory hyperkalemia, refractory pulmonary edema, refractory acidosis. Coming from there today, I can tell you I have dialyzed patients purely for volume overload. So the indications are also changing, as we have learned that fluid overload is not just a passive condition, it's a disease. And today in the etiology of cardiorenal syndrome, venous congestion is a bigger problem than forward failure and perfusion of the kidney. You need to decongest patients for them to recover, because organ, if they get edematous, they don't function well. Poisonings, science of poisoning, the treating the poisons, it's all related to critical care nephrology. So the toxicology guidelines will actually come from societies of critical care nephrology, which we are essentially equipped with the tools to treat these poisonings. Advantages, you have gone through those. Disadvantages, we should remember that these technologies are not perfect. Even today, if I have a patient with a very high potassium, I would rather put them on high volume hemodialysis, because that is a more effective form of diffusion clearance than CRRT. So you have to choose your indications right to get the desired results. marriage of therapies. That is what the future is. What do I mean by this? So you have a patient who has renal failure is on CRRT. Now this patient also requires ECMO for heart failure. Patient is not able to oxygenate. Now your ECMO is tied to your CRRT machine. This patient is not able to filter out the CO2 from the blood. You put an ECOR device in conjunction with the therapy. And now you're actually removing CO2, which is the job of the lungs. So this all falls under the umbrella of MOST, multi-organ support therapy. And in critical care nephrology, we have the means and the tools to support your organs, not just the kidney, but even heart and lungs in conjunction with other treatments to give the results. So basically, these therapies in the future are evolving towards providing or buying time till the primary illness can be settled, whether it is the heart, whether it is the lung, whether it is the kidney, whether it is the liver. There's a MARS treatment available, correct, in conjunction with CRRT, which we use for acute liver failures. So technological is okay. MARS, what I just spoke to you about. So in patients with acute liver failure with a reversible cause, this could be the end treatment. You might not need a liver transplant. And in patients where you need a liver transplant, you're buying time for the patient to remain alive till you get there. Vascular access, I'm sure all of you realize how important this is. This has been discussed. It's very important to have a good, stable vascular access and a blood which is not clotting through anything that I'm saying in the future. Treatment, it is up to us, the doctors, prescribing this treatment to decide what doses of treatment to use, what dialysate, what effluent, what replacement. Based on each patient's requirement, we can decide what to do. Anticoagulation, I spoke, whether you're using no anticoagulation, systemic anticoagulation or regional, depends on the patient, and you need to make your choices. So the future, the way I could summarize it is like this. We are going to get smart dialysis machines. AI, Internet of Things are going to help us prevent blood leaks, prevent clottings, alert us much in advance so that we don't run into these problems. Our training procedures will become so much easier with artificial intelligence, and the machines will tell us what to do, right? And then we have these biomaterials and membrane technologies. So we are going to get better and better membranes. So there won't be any reactions to our membranes. And the adsorption, which I'm such a fan of, if that technology is evolving, and just imagine adsorption. Nothing is given to the patient. You're just removing what you don't want from the blood. And this technology is only going to get better. Integrated monitoring. We can online track the patient, what is the volume status of the patient, focus available bedside, point of care ultrasound. You are actually getting a real-time thing. How much fluid should I keep removing per hour? Telehealth. I am here, your patient is in Nagpur with madam, and we are discussing a case real time. That is what telehealth is all about. And we could be exchanging ideas and helping the patient eventually. Personalized medicine. As therapies evolve, biomarkers and genetics will help us to tailor the CRRT for each individual. That will tell us it's not like a one-size-fits-all. See, today, even in the nephrology fraternity, there is no agreement on when to start CRRT, and there is definitely no agreement on when to stop CRRT. Right? And all of these treatments, these things have to come in, and that is where the future holds, because we will decide based on this. MOST, again, a big fan of MOST, because as a nephrologist, once the blood is out of the body, we are able to help not just support the kidney, but even the liver, the lungs. I mean, that's something, which I could not have thought of when I was a resident. Portability is important, so that if your devices are portable, you could use them on field. A patient with rhabdomyolysis in the battlefield might be saved if you have a portable CRRT that could go there. Educational tools. So we are trying to set up a simulation lab here at RFH, Reliance Foundation, and hopefully we should be able to have better technologies for training our healthcare providers with real-time training with a sim lab. Global health, low resource settings should get the equal rights to whatever treatments I'm talking about. And that is where the global health initiatives will kick in. Research and clinical trials, my boss used to tell me, publish or perish. And that remains true today. If we are not going to publish our research, we might as well just bin it. These advancements will aim to make the CRRT more efficient, accessible, patient-centered, ultimately improving outcomes, not just in acute kidney injury, but other critical conditions as well. Enhanced membrane technology, automated monitoring systems, integration of telemedicine, we have touched on a bit. Imagine this kind of a setup where fully bioautomatic feedback, combined data signal expert analysis, real-time labs available on the machine, patient with a focus and advanced monitoring tools telling us what are the volume status, and a CRRT machine enabled by AI and IoT to tell us whether we are going wrong at all. So AI can predict, it can personalize, and it can provide real-time care. Automated decision support, image and data analysis, and also helping further training and simulation. We should also remember that the center point of all this treatment is a patient and their family, and they need to understand what we are doing when we are doing these treatments. If not, if the treatment don't work, we are all going to get the wrong end of the stick and face into problems if they are not part of the treatment planning. Integration with other technologies like ECMO, which is already happening, research and development. By leveraging this, I personally feel that the future of critical care nephrology is very bright, and the future holds. And on the take-home message, I would like to say the future of CRRT on a global scale is very bright. The need is for equitable access, enhanced training, research, and integration of innovative technologies. By addressing these challenges and leveraging the global partnerships, the aim is to improve outcomes for patients requiring renal support regardless of their geographic location. Thank you again, Dr. Ashwini Madam, for inviting, and all of you for sparing the time to come to and attend this lecture. Thank you so much.
Thank you, sir.